Today's topic is arterial blood gas analysis and interpretation. Okay. Arterial blood gas analysis is a commonly used diagnostic tool in the mainly ICU. It is mainly done for the sick patients. Okay. And it is done to evaluate the partial pressure of gases in blood and acid-base content, that is pH, PaCO2, PO2, okay, and bicarbonate. What are the indications? We normally do ABG to get the oxygenation status of the patient, whether the ventilation is adequate or not, acid-base balance, that is pH and PaCO2, and oxygen carrying capacity of blood, and to observe the patient's response to any therapeutic intervention or any diagnostic intervention like oxygen therapy. Okay, we first do a ABG before oxygen therapy and 1 hour after oxygen therapy. So from that we can assess whether the patient getting in condition getting improved or patient is deteriorating. Okay, and to monitor severity and progression of a documented disease process. Okay, suppose a patient is suffering from ARDS. Okay, now we do a ABG today morning, then we will do another ABG afternoon or tomorrow morning, whatever. So from those two ABGs, we can determine the disease is progressing or patient's condition getting better. Okay. And what are the contraindications? There are no absolute contraindication for doing ABG, but there are some relative contraindication. First, negative results in a modified Allen test. Later we will discuss modified Allen test. Second, evidence of any infection or peripheral vascular disease. Okay. Normally we do ABG from where? From radial artery. Okay. Suppose there is some superficial or deep abscess. So that is relative contraindication for collecting ABG sample. And number 3, coagulopathy or medium to high dose anticoagulation therapy. Okay. Suppose patient is on high dose heparin or streptokinase, then that is relative contraindication of doing ABG. Sample collection. As I told before, radial artery is the most preferred site because it is superficial and we can easily access the site. But we can also collect sample from other superficial arteries. What are they? Posterior tibial artery, dorsalis pedis, femoral artery. Okay. And in neonates, we can also draw sample from umbilical artery only in the first week of life. And non-dominant hand is selected for sample collection when we are getting the sample from radial or brachial artery. Okay. Because there are some complications like maybe embolus formation, maybe infection, okay, whatever. So we will not choose the dominant hand, rather we will choose the non-dominant hand. Now modified Allen test, that is for assessment of collateral supply. Hey, mobile, there. So how do we perform modified Allen test? Okay. First, non-dominant hand is held high, okay, and the fist is clenched, okay. Then both the radial artery and ulnar artery, both the sides are compressed, okay. Radial artery is on the lateral side, ulnar artery is on the medial side. So both the arteries are compressed to block the arterial supply, okay. Then after that, when hand is lowered, then first we remove the clenching of the fist, okay. Then after fist is open, hand will blanched. Why? Because there is no arterial supply. Okay. Then after pressure is first, we will release the pressure over the ulnar artery. Okay. Still radial artery supply is blocked. Then as it is an intact superficial palmar arch, so hand and digits will get blood supply from both radial artery and ulnar artery. If pressure is released over the ulnar artery, then also hands and digits are getting supply. So if in case color should not return to the hand within 6 seconds, that means superficial palmar arch is not intact, that is compromised. Okay. In that case, we will not collect the ABG sample from that hand. Okay. Because after collecting the sample, if somehow embolus formation or any infection, radial artery supply is blocked, then there will be necrosis. We have to amputate the hand. Okay. So we will choose the other limbs or hand, that is modified Allen test for assessment of collateral supply. Now what we see commonly in the ABG. Okay. First in ABG we will see what is the value of pH, that is negative logarithm of the hydrogen concentration. Hydrogen concentration will be more, pH will be less. That's why negative logarithm. Okay. And then we will see PaCO2 and PaO2. PaCO2, that is partial pressure of carbon dioxide in arterial blood, and PaO2, partial pressure of oxygen. We will see the PaCO2 value for the to know the status of ventilation, and PaO2 to know the oxygenation status. Okay. Then in ABG, there are two values of bicarbonate. One is actual bicarbonate, another one is standard bicarbonate. Standard bicarbonate, when we get that, that is nullifying the effects of temperature and PCO2. That means standard bicarbonate is temperature and PCO2 independent. Okay. That's why it reflects the true metabolic status of the body. And actual bicarbonate, what is that? The auto-analyzer machine will get the value from pH and PCO2. Basically, machine will calculate the value. Okay. So that's why that is not the true value. And another thing, that is base excess. What is base excess? Amount of acid or alkali to be added to the ABG sample to restore the body pH to 7.4. That is the normal pH. 7.35 to 7.45 is the range, and the median value 7.4 is normal. Assuming PCO2 of 40 millimeter of mercury. Okay. And normal base excess is -2 to +2. That is the normal base excess. Okay. Now some common errors during sample collection. First is contamination with venous blood. Because artery and veins are very situated in close proximity or very adjacent. That's why very high chance of contamination with venous blood. If there is contamination, then what will happen? PO2 will be low, because that is venous blood. Oxygen saturation in venous blood is low, we all know. And PaCO2 will be high. So what are the corrective measures? What can we do? We will use self-filling syringe. So we don't have to draw. Blood will automatically come in the syringe. Okay. And short beveled needles. If we use large beveled needles, that will puncture both arteries and vein. Okay. So there will be contamination with venous blood. Another thing is air bubble. Okay. So if air bubbles come, then PO2 will be high and PaCO2 will be low. So what will we do in that case? We will expel the air by tapping gently. Like suppose this is the syringe 1 ml or 2 ml. Okay, we will gently tap the syringe. So air will collect in the topmost part and then we will expel the air. Right. Another thing, hemolysis. If we mix the sample vigorously and store the sample for prolonged period, then hemolysis will happen and potassium value will be falsely positive, high potassium. Okay. Normally, the rule is we have to do ABG within 15 minutes without ice, and if we keep the sample in ice, then 1 hour, up to 1 hour will be permitted. Okay. Now, normal blood gas values in both arterial blood and venous blood. Okay. Arterial blood gas is important, but sometimes we don't get arterial blood, so we get the venous blood. So the values in venous blood gases are also important. pH in arterial blood, normal value 7.35 to 7.45, and that is in venous blood 7.31 to 7.41. PO2, partial pressure of oxygen, in arterial blood 80 to 100 millimeter of mercury, and in venous blood 35 to 40 millimeter of mercury. Oxygen saturation will be 95% in arterial blood and 70 to 75% in venous blood. PCO2, partial pressure of carbon dioxide, in arterial blood 35 to 45 millimeter of mercury, and in venous blood 41 to 51 millimeter of mercury. Bicarbonate in both arterial and venous blood 22 to 26 milliequivalent per liter, and base excess, as I told before, that is normal value -2 to +2. So from any ABG report, we will assess depending on these values that the sample is from artery or from vein. Okay. Now, after getting the ABG report, first we will see the pH value. Normally 7.35 to 7.45. If pH value is less than 7.35, that means that is acidemia or acidosis. Okay. And more than 7.45, that means alkalemia or alkalosis. After observing the pH value, then we will assess PCO2 and HCO3, bicarbonate. So, if PCO2 will be more, that means respiratory acidosis, and body will always maintain hemostasis. So, body will compensate. Body will try to keep the pH in normal range, 7.35 to 7.45. So, there will be metabolic compensation or metabolic alkalosis. Okay. So, whenever there is respiratory acidosis, metabolic alkalosis as a compensatory mechanism will occur. And if there is metabolic acidosis, that is low bicarbonate, then compensation will be in the form of respiratory alkalosis. Okay. Respiratory compensation will occur within minutes, because hyperventilation will start or hypoventilation will start. But metabolic mechanism takes time to compensate for the respiratory acidosis or alkalosis. Now, in alkalosis, again we have to assess PCO2 or bicarbonate. If there is low PCO2, that means respiratory alkalosis. So, compensation will be metabolic acidosis. Bicarbonate will be low. And if there is metabolic alkalosis, then compensation will be in the respiratory acidosis form, that is PCO2 will be more. Okay. This chart is clear to everyone. No? Okay. Now, in compensatory mechanism, what will be the expected compensation? In metabolic acidosis, PCO2 will decrease and expected PCO2 will be bicarbonate value multiplied by 1.5 plus 8 plus minus 2. That is the range. And in metabolic alkalosis, PCO2 will be increased. How much? For every 10 millimole per liter increase in bicarbonate, PCO2 will increase by 7 millimeter of mercury. Okay. Now in respiratory acidosis, there are either acute condition or chronic condition. As I said, metabolic compensation will take time. So in acute condition, that means the duration of illness is less than 24 hours. Okay, that we call the acute stage. And in chronic case, that is 2 to 5 days. Okay, so in acute case, for every 10 millimeter mercury increase in PCO2, bicarbonate will be increased by 1 millimole per liter in acute cases and by 3.5 millimole per liter in chronic cases. Duration is more in chronic cases, so compensation will be more in chronic cases. Simple. And in respiratory alkalosis, for every 10 millimeter mercury decrease in PCO2, bicarbonate decreases how much? By 2 millimole per liter for acute cases and by 4 millimole per liter in chronic cases. Okay. This chart will be important when we will calculate that there is expected compensation happened or not. In respiratory alkalosis, metabolic acidosis compensation is fully compensated or partially compensated or uncompensated. Okay. Now, how do we interpret acid-base disorder or any ABG report? As I said, first we will check the pH. That is, there is acidosis or alkalosis, and then PCO2. Now, we have to observe the direction of change in pH and PCO2. If it's in the same direction, like pH is more, PCO2 is more, then the problem is metabolic. Okay. And if the change in pH and PCO2 are in opposite direction, then respiratory. Okay. Suppose pH is less, PCO2 is more, then the problem will be respiratory. Okay. Respiratory, metabolic and respiratory. Then in metabolic acidosis, there will be low pH, low bicarbonate, and alkalosis, high pH, high bicarbonate. Then we have to calculate expected PCO2 change with that formula we have discussed before. Okay. Then we will decide whether it is compensated or uncompensated or partially compensated or there is mixed. Sometimes there is metabolic acidosis associated with respiratory acidosis. There is no alkalosis. Okay. So that is the mixed. Same in the opposite direction, the respiratory. I am not discussing that. Now there is one thing, anion gap. When we will get any ABG report and we have interpreted that there is metabolic acidosis, then we have to find the cause of that metabolic acidosis. Okay. Anion gap will help us in that case. So what is anion gap? Anion gap is the difference between unmeasured anion and unmeasured cation. Okay. That is, from ABG, we will get the value of sodium, chloride and bicarbonate. So, we will calculate the value of anion gap. Normal anion gap is 8 to 14. Okay. In some books, it has written that normal value 10 to 12. That's okay. Normally 10 plus minus 4. Okay. Now, it helps to differentiate the causes of metabolic acidosis. Some are normal anion gap metabolic acidosis. Causes of that: diarrhea, renal tubular acidosis. Okay. RTA is not road traffic accident. Okay. This is renal tubular acidosis. And Causes of high anion gap metabolic acidosis are lactic acidosis, methanol, salicylate poisoning, any type of poisoning mainly. Now corrected anion gap, because depending on the albumin level, anion gap value will change. So we have to correct or adjust that anion gap. So adjusted anion gap in hypoalbuminemia, what will be the value? We have to calculate the difference between normal albumin and serum albumin multiplied by 2.5 plus observed anion gap. So that will be the corrected anion gap. Normally, when plasma albumin will decrease by DL, plasma anion gap will decrease by 2.5 milliequivalent per liter. So corrected anion gap is more precise. Now there is another thing that is called delta-delta gap or gap-gap. So delta-delta gap, what is that? Measured anion gap minus 12 divided by 24 minus measured bicarbonate. And what is its significance? Some cases high anion gap metabolic acidosis is associated with metabolic alkalosis or maybe some normal anion gap acidosis. Okay. So ratio will be more than 1 in case of metabolic alkalosis. Why? Because in metabolic alkalosis, bicarbonate will be more. So 24 minus bicarbonate will be low. So ratio will be more. Clear? Clear? So ratio more than 1 in case of metabolic alkalosis, and opposite. In case of normal anion gap acidosis, ratio will be less than 1. Acidosis, so bicarbonate will be low, 24 minus bicarbonate will be more, ratio will be less. Simple. Now, there is a question, pH 12 to 7.21, PCO2 32, bicarbonate 16. So, interpret this ABG. Metabolic acidosis. Explain. pH कम, acidosis base. First কি দেখতে বলা হয়েছিল? pH and PCO2. Yeah, pH and PCO2. So PCO2 কমেছে, তাহলে pH PCO2 in same direction. So what will be the problem? Metabolic. Okay. So from pH we get that acidosis, and from pH and PCO2 value metabolic acidosis. Okay. Then explain. না, নর্মাল থাকলে তো আনকম্পেনসেটেড হবে। রেসপিরেটরি PCO2 যখন চেঞ্জ হয়েছে অ্যাসিডোসিস, তার জন্য বাইকার্বনেট তো চেঞ্জ হবে। মেটাবলিক অ্যাসিডোসিস তো রেসপিরেটরি অ্যালকালোসিস হবে না। তাহলে রেসপিরেটরি অ্যালকালোসিস হলে কি করে সেম থাকবে ভ্যালু? আর মেটাবলিক যদি অ্যাসিডোসিস হয় তাহলে বাইকার্বনেট ভ্যালু কিভাবে সেম থাকবে? হ্যাঁ, ওখানে 3.5 করে কমবে না, ওটার একটা ফর্মুলা ছিল 1.5 into bicarbonate plus 8 plus minus 2 plus 8 plus minus 2 for metabolic acidosis expected compensation. So we have to calculate in that way. Okay. So expected compensation PCO2 metabolic acidosis, so compensation will be respiratory. So PCO2 value will be changed. So expected PCO2 1.5 into bicarbonate 16 plus 8 plus minus 2. So value will be 30 to 34. Okay. So the bicarbonate value here, sorry, PCO2 value here 32, and it should be 30 to 34. That means is compensated. Okay. Another thing, arekta bolchi dhor pH 7.41 note down kar nale mone thakbe na. pH 7.47. Okay, pH 7.47. Bicarbonate 16. Right. এটা একটা পেশেন্টেরই আজকেই দেখা, ওই জন্য আমি PCO2 21.4, PCO2 21.4, bicarbonate 16, pH 7.47. Explain karo ki kore. কম্পেনসেশন আছে। না না না, আগেরটা যেটা ছিল ওটা মেটাবলিক অ্যাসিডোসিস ছিল, ওখানে CO2 চেঞ্জ হচ্ছিল, এখানে রেসপিরেটরি অ্যালকালোসিস, ওখানে বাইকার্বনেট চেঞ্জ হবে। তো এটা রেসপিরেটরি অ্যালকালোসিস উইথ মেটাবলিক অ্যাসিডোসিস কম্পেনসেশন আছে। ঠিক আছে, ঠিক আছে। বাইকার্বনেট চার্ট থেকে বের করতে হবে। এইটা ঠিক আছে, রেসপিরেটরি অ্যালকালোসিস। ঠিক আছে, হ্যাঁ। সো ফর 10 millimeter mercury decrease in PCO2, bicarbonate will decreases by 2. So bicarbonate normal value, হ্যাঁ হ্যাঁ দেওয়া থাকবে। ঠিক আছে, ধরুন না এটা অ্যাকিউট কেস, ঠিক আছে, সেম ডে অ্যাডমিশন হয়েছে, দেওয়া থাকবে ওখানে ফুল ক্লিনিক্যাল হিস্ট্রি দেওয়া থাকবে। ঠিক আছে, 10 millimeter মার্কারির জন্য এখানে PCO2 কত আছে 40, এই 21। ঠিক আছে, তো PCO2 নরমাল ভ্যালু কত? রেঞ্জ বল, রেঞ্জ 32 নয়, 35 to 45। সো মিন 40, তাহলে কত কমেছে 20, তাহলে চার্জ চেঞ্জ হবে। ঠিক আছে, 4 কমবে 21, তো বাইকার্বনেট হচ্ছে 22 to 26, মানে 24 মিন, সেখানে 20 হওয়ার কথা, 16 আছে, তাহলে কম্পেনসেশন হয়েছে, কম্পেনসেশন অনেকটাই হয়েছে। ঠিক আছে, হ্যাঁ, ওখানে যদি অপশন থাকে পার্সিয়ালি কম্পেনসেটেড, ফুললি কম্পেনসেটেড, দ্যাটস ডিফারেন্ট। অপশন নেই, ওখানে কম্পেনসেশন বলেছে। ঠিক আছে, সো 20 হচ্ছে এখানে, অ্যাকচুয়ালি একটু, হ্যাঁ এখানে একটু মানে কম্পেনসেশন বেশি হয়েছে, মানে এটা ফুললি কম্পেনসেটেড বলা যাবে, ওভার কম্পেনসেটই হয়েছে এখানে। মেবি হিস্ট্রি মোর দ্যান 1 ডে, মেবি। ঠিক আছে, কারণ যদি ক্রনিক কেস হয় তাহলে ওটাই 4 মিলিমোল পার লিটার, তো 4 দুগুণে 8 for 10 millimeter mercury PCO2 bicarbonate decreases by 4. So for 20 millimeter mercury decrease in PCO2 bicarbonate will be decreased by 8. So the value will be around 16. So maybe there is probably chronic history. So that is compensated. Okay. ঠিক আছে, এটাই ছিল, এবার বাড়ি গিয়ে করতে হবে।